I'll be talking on minocycline, basically what it is and how to use it and when to use it. So the most time-tested way of killing an organism has been boiling water. Probably is the most cost-effective way of killing an organism without any side effects. So much before antibiotics came, probably beyond this there was nothing much to kill an organism. It was only in 1942 that penicillin was first put into practice, and unfortunately within 1 year resistance developed. If you look at the whole lot of antibiotics that got introduced later, if you see the time gap between introduction and resistance is hardly anything. It's at some points it is hardly 1 year, at some point it is just 1 year. That means invariably when you start using an antibiotic, resistance develops pretty early. So that's why if you look at the number of antibiotics that were put into practice, as the resistance developed, more and more antibiotics were discovered and they were started using, and as you used, more resistance developed. So ultimately you had a period where there were no more antibiotics which were being developed. It doesn't make any business sense for any pharma company to invest in R&D to bring out a new molecule. So in this respect, there are a lot of molecules people looked at which were previously used and were discarded, either because of toxicity or for various reasons, like polymyxins, minocycline, chloramphenicol, etc., etc. And minocycline is one among them. We're trying to look if this molecule, which was probably discovered much earlier, can be used for the new problems that we are facing today. So a lot of articles are being published regarding minocycline, how an old antibiotic can be reused to address the present problems that we face in the ICU. Now coming to minocycline, it's basically a tetracycline. It's a second generation tetracycline along with doxycycline, and it has got wide range of activity with respect to gram positive, gram negative, as well as atypical organisms. So it's pretty broad spectrum in nature. So the main advantage of minocycline over the other tetracycline antibiotics is that it evades the traditional tetracycline specific antibiotic resistant mechanisms. So it acts on the 13S subunits of ribosome and it inhibits the protein synthesis. That's how the mechanism of action is, like any other macrolide group. And if you look at the spectrum, see, it covers wide range. Actually, you see gram negative, gram positive, and other microorganisms. But I want you to concentrate on few things which are actually problem to us. Acinetobacter, E. coli, Klebsiella, Haemophilus, etc., etc., and also some of our ICU bugs like Listeria, Burkholderia, and Stenotrophomonas. These are our bad bugs, and these are the bugs which can easily be tackled by this antibiotic minocycline. If you look at the PKPD, 76% is the plasma protein binding, and like the usual tetracycline group, it acts the mechanism AUC by MIC. It's reasonably lipophilic in nature. That's the reason it penetrates into brain tissue well, so it can be used technically in nosocomial meningitis also, especially Acinetobacter, which I'll come a little later. So if you look at the indications, Acinetobacter, E. coli, Shigella, a lot of things, if you look at the literature, a lot of things can be treated by minocycline. But I'm here to say that don't use minocycline for all the indications that textbooks give. Now we have to sort of narrow down our indications for all the newer antibiotics that we are using today. I say to today's intensivist is like Karna in Mahabharata. When he went to war against Arjuna, he had severe restriction imposed on him on the way he should be using his arrows. That's the reason he ultimately lost, though he was a warrior. So the same problem we have today. We can't be using, though an antibiotic is capable of acting on many bugs, we should not be using the way we want, because it should be used the way it should be used, because we have to preserve those drugs a little longer. So if you look at the studies which have been done for minocycline, you should remember that either most of them are in vitro studies, they are retrospective studies. I don't blame, because you can't wait for a large RCT, with respect to antibiotics, and then for any antibiotic to be used, like typically how we have RCTs in core critical care with respect to interventions, instruments, etc., etc. So by the time an RCT, because usually a decent RCT will take 2 to 3 years time, by the time the bug profile will be totally different. And most of the studies of minocycline of late has been only on Acinetobacter, and most patients received combination therapy. There is very little data on monotherapy. So this is what you have to understand when you want to use minocycline in the ICU. So if you look at this study, they have used, this is a retrospective study again, minocycline was used against multi-drug resistant Acinetobacter, and there was reasonable good success. But here I want you to concentrate on one thing. Out of total patients, the number of patients who received minocycline monotherapy were only 3 patients, whereas 52 patients received combination treatment. Again, I was trying to emphasize that minocycline has been used in combination, mainly with a lot of drugs like doripenem, colistin, etc., etc. So technically, we can conclude that minocycline is a good drug against carbapenem resistant Acinetobacter. Now if you look at this study, where they specifically looked at Acinetobacter as well as Klebsiella, both carbapenem sensitive and resistant organisms, you see that the statistics are quite in favor of using an Acinetobacter also in carbapenem resistant Acinetobacter. Whereas if you see in Klebsiella, it's not very encouraging, right? But this is an in vitro study, please remember. So in this in vitro study, what they found was, for carbapenem resistant Acinetobacter, it's a good choice, but for carbapenem resistant Klebsiella, it might not be a great option. This is based on this in vitro study. Whereas this study, when you see in this group, there were 5 patients who were, carbapenem resistant Klebsiella was there, and in this study, all the patients, this group, which were carbapenem resistant Klebsiella, they were sensitive to minocycline. So it's very difficult to draw conclusions based on, this data. So what I did was I looked at my own hospital data. I thought that will be better than going with all these small studies. So the problem we had was excessive use of meropenem at one point of time, because any sick patient on multi-organ support in shock, obviously hospital acquired, we start with meropenem as an empirical choice, right? So patient receives a couple of days of meropenem, and then you come to know that patient has got a carbapenem resistant Enterobacteriaceae, and because you can't give colistin monotherapy, you end up adding meropenem with colistin. So technically, buckets and buckets of carbapenems were used. Much of it was only empirical, not targeted. So our strategy was, we wanted to reduce the carbapenem usage in the ICU. We were looking for strategies, and we wanted to see how best we can fit this drug. This is our bug profile. Klebsiella was still one of our bad bugs, following by E. coli. Our Pseudomonas are relatively decent, they are well behaved. So we are not too worried about them. We are mainly worried about our carbapenem resistant Klebsiella and E. coli. This is how our Acinetobacters behave, the sensitivity pattern. But if we specifically looked at minocycline sensitivity in carbapenem resistant Enterobacteriaceae, minocycline sensitivity was 100%. This is our data. So if you look at, this is with respect to E. coli, this is our data, this is how our E. coli behaved totally. I am writing minocycline separately because it was our understanding between us and the microbiologist not to look for minocycline sensitivity and not to put it on paper unless the intensivist specifically asks for. Because if it starts coming on the printed paper, you know, the moment you see yes, people will start using it indiscriminately. So it was our understanding that unless we ask for, you know, not to put it on paper, you know, that's why I am putting it separately. So if you look at minocycline sensitivity in carbapenem resistant E. coli, our sensitivity patterns were almost 80%. Carbapenem resistant Klebsiella, this is how our bugs behaved, and the minocycline sensitivity was 70%. So this is what has been our journey, you know, about managing carbapenem resistant Acinetobacter. Previously, you know, we used to bomb them with colistin with meropenem, though it was carbapenem resistant Acinetobacter, because the logic was that, you know, it has a synergy and meropenem acts on cell wall, it weakens the cell wall, and colistin has got a detergent effect over the cell membrane, so have that, you know, they have you know, synergy. So that's why we have to use this. And later, because I told you we were using meropenem in buckets, so we wanted to reduce, so we decided to go in for colistin plus sulbactam. This is what was our next strategy. It worked decently, it's not that it didn't work for us. But the problem here is when we discuss with, you know, there were some clinical failures we wanted to analyze when we discussed with our microbiologists. There is no CLSI breakpoint cutoff for sulbactam, this one. So we have to use sulbactam, you know, assuming that it works. There is no, you know, breakpoints that are available either by CLSI or the other group for to know whether it is sensitive or resistant. That's why, you know, we had our own doubts whether we should be continuing with sulbactam. Then next, of course, we went in for polymyxin B plus minocycline, and this combination is actually working for us in most of our carbapenem resistant Acinetobacter infections. Now the next thing is whether minocycline monotherapy should be used or not, especially in, say, carbapenem resistant Acinetobacter. That was our question. And to be very honest with you, I have used it in 2 patients, both of them were VAP patients, okay, and they didn't do bad. But if you ask me, should I advocate, you know, minocycline monotherapy for carbapenem resistant Acinetobacter, I don't have easy answers at present. I would rather err on the side of caution and say no. So this has been our journey when it came to carbapenem resistant E. coli and Klebsiella. For the same logic, we were using colistin plus meropenem initially, high dose meropenem and colistin, and then we shifted to polymyxin B plus minocycline. The problem here is that, you know, when we also analyzed the data, we were seeing lot of carbapenem resistant, colistin resistant strains in our ICU, especially Klebsiella. And we also were thinking about what possible strategies we can have to spare colistin. So at present we are contemplating whether we can use minocycline with fosfomycin. So please try to understand, unlike in, you know, many aspects of critical care, like either it comes to concepts or instruments or anything for that matter, you can do RCTs, wait for the results. But here, you know, the bugs are so intelligent, by the time you do an RCT for 2 to 3 years and come up with a publication, bugs will start behaving differently. So we need to have some innovative ideas and see how best it will work, you know, depending on your system. Obviously you can't go by the data of some other hospital or some other country. Each hospital, you have to sit with your microbiologist and see your data and then have your own solution for the problems that you face. Now when you manage, you know, bad Klebsiella, this is what you have to specifically look for. Whenever you grow a carbapenem resistant Klebsiella, please call your microbiologist and ask them, are they mucoid Klebsiella? These group of bugs actually, they produce hypermucins, and, you know, which which will make the antibiotics ineffective. Either you have to increase the dose or the duration should be more. You know, they do what is known as a string test. So whenever you come across carbapenem resistant Klebsiella, please talk to your microbiologist and ask them if they are mucoid Klebsiella. Probably in those cases you might have to increase the minocycline dose if you are using from 200 to 4 this thing, okay, and or better use fosfomycin. So what we actually achieved when we did all those things, right, the empirical use of carbapenems came down by almost 80% in our ICU when we actually looked at data. As on today, you know, if you ask me, the very few indications where actually we use empirical carbapenems in ICU. One of the things is where diabetic patients come with complicated urosepsis. One of the indications to use, in shock, of course, we use carbapenems. Otherwise, you know, everybody is asked to question in case you want to just throw in a meropenem, you know, just because you don't know what is happening or patient is very, very sick. At one point, you know, any patient coming with shock, you know, people had a tendency to meropenem. I always used to tell that meropenem is not a vasopressor, it is an antibiotic. So please don't use meropenem as a vasopressor, use it as an antibiotic for what it is meant to be. So the next thing, you know, when we brought this down, we saw a lot of benefits. You know, actually we did have problems with Burkholderia Strenotrophomonas. The load, I mean, there was a reduction in Burkholderia Strenotrophomonas. You can argue that minocycline does have an action on Burkholderia Strenotrophomonas. So probably that's the reason why your Burkholderia Strenotrophomonas, have come down. I wouldn't argue against it. But I am just trying to tell you guys what we did and what we are seeing. And of course, there was some change in the drug sensitivity, mainly I feel because we did reduce the amount of carbapenems, empirical carbapenems we were using in the ICU. So dosage, 200 loading followed by 100 mg every 12 hourly, you should remember. But one thing please remember is what you dilute. Okay, our routine thing of putting in 100 ml normal saline and giving it over 1 hour might escape if you have a CVC, but if you have a peripheral line, it will lead to bad thrombophlebitis. Initially, when we started off, you know, after starting minocycline, patients having fever, you know, when we looked, you know, patient had bad thrombophlebitis. Then we went back, looked at literature. And then when we spoke to them, they said you have to use something like, you know, 200 to 500 ml dilution. And I said, you know, if you start giving 1 liter of fluids just to dilute your antibiotics, you know, we will have serious trouble. So what even if a patient has a CVP or a peripheral line, nowadays we ensure that we dilute it in say 250 ml of normal saline and give it. And with that, the incidence of thrombophlebitis has come down very drastically. So take home message, please remember, you know, I was just telling Gansham before this talk that there are few things which does not need a qualification, okay, to become a politician, to become a father, to become a husband. Unfortunately, even prescribing antibiotics falls in that category. Anybody and everybody can prescribe antibiotics the way they want, okay. So this has to be done responsibly. So this is you know, relatively new to our armamentarium, and we have to use it very responsibly because data is mainly retrospective in nature, and definitely it is the use has been approved against Acinetobacter. So no thought about it. Carbapenem, not every Acinetobacter, carbapenem resistant Acinetobacter, and please try to use in combination because the data on monotherapy is quite less. If you want to use against E. coli and Klebsiella carbapenem resistant, please sit with your microbiologist, look at the data, only then take a decision. Please don't use because, you know, going by our data, so you have to sit with your microbiologist and have a data. So depending on the sensitivity, try to use it. And if it is carbapenem resistant Klebsiella, ensure that it is not a mucoid Klebsiella. If it is a mucoid Klebsiella, you will have to use it in higher doses. Thank you so much.